Right. So I'm going to go run through very quickly about something that what it kind of work, right? So DME work, exudation that Peter mentioned earlier, that you can see that OCT changes, and you can see that exudate disappear as the edema disappear. And then how close you can go. I think that we had slightly divided opinion how close that you can go. We already showed that you can actually go very, very close. And I tend not go to up to about 50 to 100 microns, so almost there. So it's not really, transfoveal or not is debatable. As you can see, that work, and it's just like Dr. Firoy have showed you earlier. And vein occlusion is a bit controversial. I think sometimes that, certainly a massive vein occlusion inject, but then some mild one, either you can just watch them, and make you feel happier, you can do some treatment. And again, that seems to work very well as well. And we already seen that CSR, and again, you can see how close it can go. And again, it depends on where you are, because you see, like in the UK, PDT, you have to pay for it, and micropulse, you can have it in the health service. So I would do micropulse first. But again, if I want to make more money, I would then take the patient to private. But again, I tend not to bother. And so you can go quite close, and this is a case that goes very close, and it kind of work. And this one even closer, and it kind of work. And different even closer, and it kind of work. Chronic cases slightly more difficult, quite often need more than one treatment. And again, like in the PLACE study, that the success rate is lower. We certainly have seen the same experience that you might want to treat it with one modality, and then if it doesn't work, we go to other. So I certainly have experience that have two micropulse doesn't work, and then work and go to PDT, then they work. And I have certainly had patients that had PDT failed twice and then referred to us for micropulse, and then it worked. So I don't think that is, we haven't got a clean idea on those cases that one seemed to be preferred than other. And this is another case that it kind of worked. So at least that's from my point of view, diabetic macular edema, maybe vein occlusion, CSC work. So I think that's clean, right? And then what else is published? I think there's a talk. I just want to say something is when 6 big academic group, 200 paper, I think you can believe it. If one author or 2 paper by the same author or 10 paper by the same author, and in someone who is particularly not associated with any academic institution, you worry, right? Don't think it's wrong. In fact, that there's some people might have a very bright idea, but something that you need to do with caution. So proliferative diabetic retinopathy was raised earlier, and there's one paper about it, and we have given it a try, and it doesn't work. Okay, but if you want to try, feel free. Macular aneurysm, that again, there was a publication about it, and we try, and it seems to work. So again, we haven't published it because it seems to work. So that might be the caution I say that. Well, think about it. There was some idea about people who have neovascular AMD when treated quite repeatedly, and it doesn't seem to work, and then you laser it, and then you seem to work better. And again, we tried it, and it seems to work. So again, I'm just telling you anecdotal experience on that. However, bear in mind, Dan Martin published a very nice paper on the CAT study analysis. They look at people who are so-called not responding, and then define that group as non-responding, and then look at them, what happened to them 3 to 6 months later. But in the CAT study, as you know, that there was no treatment change. They would keep on having Lucentis again. And in that group, they also get better. So again, that when you try to change a therapy in a group of patients who already have poor outcome before, your change of therapy might not really true. But again, so that is why that I can give you an antidote experience. So if you have really time, you can do a control trial and then figure it out. Polypoidal, and I'm still trying to persuade someone to do a study on it. Certainly in Asia, even PDT is too expensive, let alone injection. I mean, injection works beautifully. So don't get me wrong. In the UK, we would just ignore the so-called PCV, just treat them as wet AMD, and then give them Eylea and work, or anti-VEGF. But just be fair. Probably why it's slightly better. But again, in Asia, you can't afford PDT, but laser may work. And again, we have a couple of cases that seem to work. We try to persuade a group in Asia to do that study. So if you are in Asia, want to do that study, think about it. We have done some study in Jerusalem, both in Russia and in China, and they still haven't published it. They have shown me the data, and it seems to work. And that's also why I said that in Royal Free that we are starting a trial, but it will be a control trial because again, all the previous case series, always this worry that you might be just, when you're doing something and you think that you work, but then, but we were going to do a control trial, so we have a sham group. So hopefully that will give you some answer in the next couple of years. But it takes a long time to get a control trial to start in the UK, unfortunately. So again, this slide looks a little bit old because there's a few publications actually since 2015 have published. I still feel that even they publish, it's still not necessarily true if there's still one author. So it seems to work in retinal pigmentosa, Stargardt, and geographic atrophy. So there's no treatment for any of those diseases. And if you had a treatment for geographic atrophy, like Apellis, APL2 is a terrible drug in my opinion, but they probably still sell more than $1 billion. So if MicroPulse were, brilliant, it would be fantastic, And then I'll probably leave Boehringer Ingelheim. It's no point for us to develop drug anymore because we want to develop drug for Stargardt and geographic atrophy, right? And you seem to talk about microperimetry, and you seem to improving within weeks. Well, to be fair, if you just put the hand over some patient head, but then when you do the second time microperimetry, you often do slightly better because you now learn how to do it, just like visual field. You don't do the first time, ignore the first 3 or 4 micropulse normally, and microperimetry anyway. So again, microfocal ERG, I have no idea why that it would work. But again, we have known that laser induces glial cell response. So whether it's just a glial cell response will improve your microfocal ERG, but doesn't actually improve any function. So again, something that I worry about. So from my point of view, to close the session today, I will basically say that, well, I think that if you do DME and CSR, if it doesn't work, for DME, it's usually that it's too thick, the retina. You might need to do anti-VEGF. And as you know that even with anti-VEGF, it doesn't always work. So don't be fooled by us to say to you that DME always work. And again, if I said that, if you thought I said that, then it's wrong, right? So I think anti-VEGF is still better than laser in most circumstances. But the point is whether can you really keep on the injection and so on. So I think that with micropulse or SubLiminal laser is much better than conventional laser. I think we should stop doing conventional laser causing retinal damage. But, doing the both together is something that we should definitely consider. CSC, it kind of worked. And as I mentioned that, I would treat as early as possible. I think it's slightly different, again, that from our German colleague is slightly more conservative. And because we think that we're now treating people well and then we don't need to wait. That is always true that some patient would benefit, would spontaneously recover. But since you can't predict who is that 5 or 10% who don't spontaneously recover, then you worry. Or the other, then I will let you to make the decision. Read the paper rather than just listen to the talk on the person who wrote the paper. And if you really think that, over 5 years now, no one have republished another paper on the same subject, I worry. And thank you very much for coming. And I really appreciate that you're here.